الحقيقة احنا عندنا two sessions في بعض. السيشن الأولانية في invited guest speaker international speaker، ثم هنبدأ السيشن بتاع الفارماسيوتيكال كومبانيز، وهي مجموعة من البرزنتيشنز، وإن شاء الله تستمتعوا يعني بهذه السيشن بإذن الله وتستيقظوا كثيرا. يلا
بسم الله الرحمن الرحيم. We call for the opening of session 14, session of the Midday Expert International Speaker. We are delighted to have with us Professor Khalid Ismail, the instructor of medicine at Harvard Medical School, assistant professor of medicine at Tufts Medical School. Professor Khalid Ismail is from Alexandria University, and he moved to the States several years ago, and he will be with us with a recorded lecture. We will view this half of this lecture today because unfortunately we are out of time and it's a recorded session and he will not be able to be with us today, but we will try to be with us in tomorrow inshallah to answer the questions, and tomorrow we will introduce the second part of this session inshallah. The presentation of Professor Khalid will be concerning the hot topics in obstructive sleep apnea.
Hello, everyone. Khalid Ismail. Happy to join you all from Boston. This is my second year attending your conference, and I'm hoping to talk about hot topics in obstructive sleep apnea. This is just a quick, just brief bio. Proud to say that I'm a graduate of Alexandria University. I graduated in 1995, and I've been in the United States now since '98. Finished my training, got my board certifications. I'm board certified in pulmonary critical care and sleep medicine, and I'm currently at Brigham and Women's Hospital, and I teach at Harvard Medical School. And I'm very happy to be with you. I have no relevant disclosures. Just the outline really is to briefly go over just the basics of obstructive sleep apnea, talk about the pathophysiology of disease, some of the newer areas of research that we are looking into, look at some of the available diagnostic modalities and newer technologies, different treatment options, some of the new and promising interventions, and the future of OSA treatment. So we'll start with the case. So we have a 48-year-old man with difficult to control high blood pressure on 3 different blood pressure medications, has atrial fibrillation, recently failed ablation, diabetic, hemoglobin A1C is 9%. He has erectile dysfunction, memory impairment. You know, he's in your clinic, and his wife says that he has snoring, only soft, but he does have episodes where he gasps for air while asleep, sounds like he's choking, denies any trouble sleeping. He himself, the patient, denies any trouble sleeping or excessive daytime sleepiness, but he's tired throughout the day. He is obese, BMI is 42, neck circumference is large, 17.5 inches, and his blood pressure is 165/95. And when we look into his mouth, the back of his mouth, he has crowded oropharynx. This is what we would call Friedman class 4. And just for reference, Friedman classification goes from class 1, 2, 3 to 4 when you cannot see any part of the soft palate or uvula. And that just, indicates a high risk for upper airway obstruction during sleep. So the first question is, what should be an important next step? There are many things we can do for this patient, but should we, first step, rule out thyroid disease, evaluate for the secondary cause of hypertension, rule out obstructive sleep apnea, evaluate for renal disease, or evaluate his diet and exercise program? Just an easy, just a kind of like a wake-up question. So I'm not going to spend too much time here. I think the right answer, I think you all probably guessed it right, rule out obstructive sleep apnea. So there are many red flags in this case. This is someone who has resistant hypertension on 3 different blood pressure medications, failed atrial fibrillation ablation procedure, has erectile dysfunction, has poorly controlled diabetes. The wife noticed those episodes of choking, witnessed apneas. They're very, very specific for obstructive sleep apnea. The high BMI, the large neck circumference, the oropharyngeal exam. The thing with obstructive sleep apnea, there are a lot of things that we can do for this patient, but if we don't diagnose and treat his obstructive sleep apnea, we would not be able to have, good control of his comorbidities. And so if we just talk about the basics here for a second, so I'm sorry. The way we define obstructive sleep apnea, so it's upper airway obstruction that occurs only during sleep. And we define the upper airway, or we divide it into 3 stations: nasopharynx, oropharynx, and hypopharynx. And narrowing at any of these stations, at the nasal septum deviation, any problem with at the oropharyngeal level, a very long soft palate, very large tonsils, a large base of the tongue. Any of that, when combined with loss of muscle tone that occurs during sleep, as we can see here on this dynamic CT scan, will lead to upper airway obstruction during inspiration. And many experts look at this as a spectrum of disease, where you can have, normal into like very, very slightly obstructed airway that can cause snoring, into partially obstructed airway with hypopneas, into completely obstructed airway with obstructive apneas. And we can look at it as a continuum of disease, where the patient can start from snoring, but then with more upper airway obstruction, they can have upper airway resistance syndrome, where we see RERAs, or respiratory effort-related arousals, that we can diagnose on a sleep study. But then we start to see 30% or more flow limitation, and which we would call obstructive hypopneas, and 90% or more limitation of airflow or obstructive apneas. Then they start to have daytime hypoxia and hypercapnia, and that's what we would call obesity hypoventilation syndrome. And the way we define define severity of the disease is what we call, apnea-hypopnea index. So the total number of apneas and hypopneas that occur throughout the night divided by the number of hours of sleep. And if that number is less than 5, it's considered not clinically significant. If it's 5 to 15, it's mild. 15 to 30, it's moderate. More than 30 is severe. So that's the traditional way of diagnosing and assessing severity of disease. You'll see some labs using the RDI, or Respiratory Disturbance Index, which adds RERAs, those upper airway resistance events that I was talking about, in addition to the AHI, and we still go by the same cutoffs. Less than 5, and then more than 30 is severe. The problem is, this is very limited, and there is a lot of research going on right now, and maybe this is one of the very first slides that we talk about hot topics in obstructive sleep apnea. How do we better define the disease? We know AHI is not the best definition of disease or disease severity, because we see, all of you guys see patients with an AHI of 40 or 50, but maybe they don't have significant desaturations, or they're maybe not very sleepy. We see some other patients with very mild disease, but they're very sleepy. Other patients have significant hypoxia. Some patients, one of the newer concepts is this nocturnal blood pressure dip loss. So loss of the natural or normal nocturnal blood pressure dip. Most people, when we go to sleep, normally blood pressure would drop by 10 to 20%. Patients who don't have that drop, don't have that dip, are, there's very strong correlation with cardiovascular morbidity and mortality, and high blood pressure during the daytime, among other cardiovascular problems. So we know that there are more to the story than just the apnea-hypopnea index, and there is a lot of research going on right now to maybe come up with a better cardiometabolic risk assessment and risk severity of the disease. So be on the watch out for that. If we look a little bit more about the pathophysiology of obstructive sleep apnea, and this is basically what I tell, each patient when I see them for the first time and just get their attention to talk about what is obstructive sleep apnea. Basically, I tell them, you go to sleep at night and the deeper you go into sleep, you start to lose your muscle tone. The muscle tone in your tongue becomes weaker, and then depends on your body position, your tongue can fall backwards, and depends on how narrow your airway is, you can start to have, obstruction of the airway, you choke on your tongue, oxygen levels go down, CO2 level go up, then alarms go off, your body's trying to overcome that obstruction and get over that choking event. So with adrenaline kicking in, the sympathetic system is activated. There is an arousal in the brain that we see on the EEG. So sometimes they don't wake up, but the brain now goes from deep sleep to lighter sleep with return of the muscle tone, relief of the obstruction. And they start to breathe again, and their oxygen and CO2 levels correct. So, and that episode can repeat itself throughout the night. So someone with an AHI of 30 per hour, for example, these episodes are happening every other minute. And we can see this in the sleep lab. So in this study, it was an older study, was done actually with an arterial line. So a line monitoring the blood pressure throughout the night and monitoring of the sympathetic nerve activity as well. And as we can see towards the end of an apneic event with arousal, there is an overshooting of the blood pressure that can go up as high as 220 over 120 because of sympathetic activation. And then once that arousal is gone and they try to go back to sleep, the blood pressure starts to go back down and so on and so forth throughout the night. So we see this constant episodic elevations in blood pressure. So it's not a surprise that resistant hypertension, one of the most common causes of that is untreated obstructive sleep apnea. This study was recruited patients, actually there were multiple studies that showed the same results. Patients recruited in cardiovascular clinics with resistant hypertension on 3 or more blood pressure medications with no good control of their blood pressure, and obstructive sleep apnea was the primary underlying etiology. More common than, just primary genetic hypertension, other things like, renal artery stenosis, pheochromocytoma, things that people usually look for, but, sometimes they don't think about obstructive sleep apnea. There is strong association, as you can imagine, with cardiovascular disease. We see here in this study, they looked at association with these variable cardiovascular morbidities. This range here, the lower end of the range represents patients with AHI of 15 or more, so moderate to severe disease. And the higher end represents patients with an AHI of 5 or more, so any sleep apnea. And we can see very, very strong associations across the board, stroke, hypertension, arrhythmias, specifically atrial fibrillation. We also see a strong, correlation with some of the metabolic derangements, specifically with diabetes and hemoglobin A1C, one of the biomarkers that we use for control of diabetes. So we can see linear correlation between how severe obstructive sleep apnea is and the hemoglobin A1C levels. And that's after adjusting for all variables like, age, sex, body mass index, number of diabetes medications, levels of exercise, years of diabetes, and total sleep time on polysomnography. So you can look at obstructive sleep apnea as a multi-system disorder, really. So in addition to all the cardiovascular comorbidities we talked about, cerebrovascular comorbidities, the metabolic changes we see, especially with insulin resistance, we see problems with cognitive function and memory. We see a problem with sexual dysfunction, and we see, of course, excessive daytime sleepiness and risk of increased traffic accidents and workplace accidents. In addition to that, large cohort, epidemiologic studies like the Wisconsin sleep cohort, for example, followed patients for 18 years and found that there's 4-fold increase in all-cause mortality and 5-fold increase in cardiovascular mortality in patients with severe obstructive sleep apnea, AHI more than 30. And that's, again, after adjusting for things like age, sex, and body mass index. So here in the pathophysiology of disease, there also has been huge interest in just going beyond the phenotypes of the patient, looking at the epigenetics. And basically, the way I look at it is just how environmental factors can modify, post-translational modifications that happen in gene expression. So you can think of chronic intermittent hypoxia, for example. How can that affect gene expression? And there are many areas that are being looked at. All that is really very hot area of research right now. And we can see that intermittent hypoxia can cause DNA methylation, can cause histone modification, can cause this non-coding RNA regulation, microRNA. And these things can lead to oxidative stress, inflammation, apoptosis, cell proliferation that can lead to all the clinical syndromes that we eventually see. So, and all these changes can happen at variable extents in variable patients, depending on how much chronic intermittent hypoxia affects their post-translational gene expression. So, and that might explain why we have patients with severe obstructive sleep apnea who don't develop cardiovascular disease, while others with mild to moderate sleep apnea that do develop cardiovascular disease, stroke, and other comorbidities. So I think, this is very exciting, and I think we will see more data coming out from that space, looking at better understanding the pathophysiology. Some of these things we can use as biomarkers for detection of disease very early, before even patients develop the disease, or it can help us, guide treatment as well. So when it comes to screening for obstructive sleep apnea, some of the traditional ways we or tools that we use for screening Epworth Sleepiness Scale, for example, which we use very commonly here, and probably you guys use in Egypt as well. The problem with it that it's not very sensitive or specific. It basically asks patients, what are the chances, what are the likelihood of you dozing off while doing some of these passive activities, just sitting and reading, watching TV, sitting in a car as a passenger, sitting on a couch, etc. And any score that's higher than 10 is abnormal. But again, not very sensitive screening tool at all. So newer tools have been developed, like the Stop Bang questionnaire, for example, which adds things like blood pressure, snoring, BMI, age, neck, gender, which all made it more sensitive and more specific. The Berlin questionnaire, same thing, added variables like blood pressure, and was also shown to be much more sensitive and specific. So these questionnaires now are being used in areas like preoperative screening in primary care. And the area that's very exciting now with the screening is, and I'm sure you guys see this also in your clinic, every patient walks in telling me, I bought this new mattress that can detect how good my sleep is, the quality of my sleep, all the smartwatches that are out there, ring device that goes over the finger. All these things can be connected with phone apps, and patients look at this and come to your clinic and ask you, look at my sleep, and what does that mean? My sleep is poor, the quality of my sleep, I'm not going into very deep sleep. So all these tools are really improving, very, very quickly. And at this point, we're not using them for diagnosis, but we use them for screening. So if any of these devices show that the sleep is very fragmented, for example, some of them can even detect snoring, it's an indication for us to, okay, let's take it to the next step and try to get you a diagnostic test, proper diagnostic steps. So just one very quickly area I want to mention here is the screening for OSA in the perioperative space. So this is a huge area of focus now in many hospitals here in the United States, trying to screen for obstructive sleep apnea before surgeries. And this would just allow us to manage these patients differently in the intraoperative and the postoperative setting. You know, close monitoring, ask them to bring their CPAP machines or use CPAP while they're in the hospital to decrease the risk of post-operative complications. Okay, which brings us to our next question now. So the patient that we talked about earlier in our presentation here, now we suspect obstructive sleep apnea and you want to make the diagnosis. So what is the next step? Do you just start them empirically on CPAP therapy? They definitely have OSA and we want to start CPAP. Or do you order an in-lab sleep study? Do you order a home sleep study? Do you ask the patient to monitor his sleep quality using his smartwatch? Or do you ask him to avoid sleeping on his back and that's it? I'll give you a couple of seconds to think about it. So again, the right answer here is to order the sleep study. We need to make the diagnosis. So definitely we need to establish a diagnosis. We, at least here, again, in the United States, to get the insurance to pay for it, we need to make the diagnosis for that reason, but also just to be sure of, and to know how severe the sleep apnea is. Whether we do in-lab or home sleep testing, I'm going to go over this in more detail now, but, home sleep testing for the most part is more convenient and more cost-effective. Wearable technology, as I just mentioned, they are up and coming, but they're really not approved for diagnosis yet. And, most sleep apnea is worse in the supine sleep when people are sleeping on their back, but, we don't even know if he has obstructive sleep apnea or not. And then we need to look at the sleep study and see if the disease happens mainly on their back or their side. So the right answer here is just let's establish a diagnosis, and we can do this with a home sleep study. So sleep testing for obstructive sleep apnea, the three major, modalities that we use are in-lab testing, home sleep testing, and then some very limited wearable devices that have been FDA approved here, at least in the United States. One of them is the peripheral arterial tonometry, the watch pad, and I'll go over that in more detail. So the in-lab sleep study, this is your traditional study. Patients always think about it and like, how am I going to ever be able to sleep with all the wires connected? But the reality is, they all have OSA. They're all very tired, and once we turn off the light, they fall asleep for the most part. What we get is a very comprehensive set of data that looks at EEG, EMG. So eye movements for REM sleep, chin muscle tone, EKG, leg movements, airflow, of course, snoring. We can detect snoring with a mic, chest movements, abdominal movements, and oxygen saturation and body position. Very, very comprehensive test. And as you can see in this example, this is someone who you can see this is flow, and this, by the way, each of the distance between these two lines is a 30-second epoch. So we can see that almost every 30 seconds he has this flow limitation, followed by the airway opening again and snoring, and then them breathing, and then again obstructions, flow limitation, despite the chest and abdomen moving, trying to breathe, and then the airway opens up, snoring, and so on and so forth. So this is someone with very severe obstructive sleep apnea. And with each one of these episodes, we can see oxygen desaturation following the obstructive event. So that's in-lab testing. So home testing, on the other hand, is much simpler. So the idea is you only need 3 or more sensors. We need a nasal cannula to detect airflow. We need a chest and an abdomen belts to detect thoracic movement, and an oxygen saturation probe, which will also give us heart rate and other data. And, the newer kits, you can add more and more leads to this, but the idea is patient, get this connected. They connect themselves at home, they sleep with it, they wake up the next day, they send us the kit, and we download the data. And that's what we would get. So you will get much limited, parameters. But again, for someone like this, for example, this is flow. You see the flow signal, and then it stops. Flow signal stops. This is effort. This patient is trying to breathe despite no flow. Chest and abdomen is moving despite no flow. We see the significant oxygen desaturation. So this is obstructive sleep apnea. And you can see it's repeating. This is a minute period. And this is a hypnogram throughout the night. We can see many, many, many events happening throughout the night. This is someone with very severe obstructive sleep apnea. As far as, so there are newer devices that are being tested in the United States here, almost every few months we see a new device that come out. They're all smaller, smarter, using, different sensors and looking at different parts or aspects of sleep. The problem is none of them are really FDA approved yet, and as I mentioned in our previous slide, we are using them for pre-screening, maybe home screening. Have them come with it and talk to you. Oh, look at my sleep. It's disrupted. There is snoring. Some of them even measure oxygen saturation, but we should then go ahead and get a proper diagnostic test. So one of the approved ones actually is the actigraphy, which has been around for a while. And basically, I think many of the smartwatches use the same technology. It basically converts wrist movement into an estimates of sleep versus wake cycle. So there's computer algorithms that automatically scores wake and sleep based on activity counts. And we set like a wake threshold there. And basically that's what you need. So this is a 7-day recording, for example, and these are activities, all these black bars. So you can see this period here is considered sleep. And this, if you can see 8 p.m. So this patient went to sleep at like 9 p.m., woke up at 6, went to sleep at 10 p.m. that day, woke up at 8, and so on and so forth throughout, a week of recording. So we don't diagnose obstructive sleep apnea with this, but, it's very helpful for us, much better than a sleep diary, for example. It tells us just what the sleep schedule and the sleep pattern is of a patient. We can see, for example, that night here, there was a lot of sleep disruptions. We can see a lot of these disruptions. Then we use a treatment for sleep apnea, and then we can see that it improves, like the sleep quality improves. So it has some use in our managing of obstructive sleep apnea, but we use it more often for circadian rhythm disorders and insomnia. So peripheral arterial tonometry, or the watch pad device, it's been around now for more than, I would say, like 10, 15 years. There are newer generations of it, but it's very interesting. And I don't know how many folks use it down in Egypt, but it's, as you can see, that we don't have any cannulas over the nose or the face area. It all uses so that actigraphy-like device on the wrist. So there's a wrist device that is this probe on the finger. If this arrow allows me, here you go. This probe that goes over the finger measures actually the arterial, vasoconstriction, so arterial muscle tone. And I'll show you how it works here. So basically, with every upper airway obstruction that occurs, an upper airway collapse, we see there's feedback with sympathetic activation, as I mentioned to you earlier in this presentation. This sympathetic activation will cause vasoconstriction, heart rate acceleration, and what is called a peripheral arterial tone attenuation, PAT attenuation. Okay, and this PAT attenuation, when combined with snoring and combined with oxygen desaturation, it's counted as obstructive apnea. So, and there's also another probe for oxygen and heart rate changes. So these are the sensors that you can get with this device. So again, there is actigraphy built in here to differentiate between sleep and wake and how deep sleep is. There is the PAT sensor in here. There is an oximetry for oxygen saturation and heart rate. There is a body position sensor. There is even some of the newer modalities have a chest motion sensor, so it can tell you if there is effort, so it can tell you differentiate between obstructive and central apneas basically. So the technology really developed, and it is FDA approved here in the United States. We can use that actually for the diagnosis of obstructive sleep apnea. This is the report that's generated. And as you can see, you get something like AHI, but it's called PAHI because it's done with this PAD device. But you can see, I mean, the numbers are, the cutoffs are the same. So this, for example, in this study, the PAD AHI is 33 per hour. So this is someone with severe obstructive sleep apnea. And we can see events happening in the supine versus non-supine position. We see it all. These are some of the graphs. So those are the events that are happening throughout the night. The orange here are all the snoring that's happening. This is body position. So in this example, you can see this is someone who goes from the right position to the back position, and on their back, they're having a lot of events, then back to the right, then back to the back position. And so predominantly supine obstructive sleep apnea, oxygen desaturation happening every time they go on their back. And then this is the sleep-wake cycle throughout the night. Detected by the device. So pretty good data, and we can start treatment based on that. But just to summarize, really, who is the best candidate to get a home sleep device and do a home sleep study on? So it is someone who you have a high pretest probability for them to have moderate severe OSA, obese patient, very crowded oropharynx, that kind of thing. It is someone that doesn't have significant cardiopulmonary or neuromuscular disease because if they're desaturating or having problems because of their heart or the lungs or neuromuscular disease, you won't be able to tell. You're only looking at flow, oxygen saturation, and chest movement. You should not suspect any other sleep disorder. This home sleep testing is really for OSA alone. So if you're thinking about something like, periodic leg movements, parasomnias, insomnias, all the other sleep disorders, we cannot use home sleep tests. It can be considered for patients who cannot come to the in-lab. For example, we do here nursing home patients or patients in rehab facilities. So we can use a portable device for that. And then we can use it also if someone got started on an oral appliance or a treatment for obstructive sleep apnea, and we want to know if their sleep apnea is much improved, we can do a home sleep test for that. So back to our patient. So we did the sleep study and we made the diagnosis. So he does have obstructive sleep apnea. His AHI is 12 per hour. His oxygen saturations go down to 70%. What is the best next step? You start empiric auto CPAP. Do you refer to a dental sleep medicine provider to get an oral appliance? Do you recommend hypoglossal nerve stimulation surgery or Inspire? Do you do a weight loss? You recommend weight loss and that's all he needs, or do you recommend positional therapy? I'll give you 2 seconds. So the right answer here is to just go ahead and start empiric auto CPAP. This patient has an elevated BMI. There's very high pretest probability. He does have mild sleep apnea. He has significant oxygen desaturation, and he has cardiovascular disease. So CPAP is probably the best treatment option. We're going to talk about what are the best indications for each treatment modality in a minute. But the reason, you don't have to, you can send, of course, this patient to the sleep lab for a CPAP titration. But just, in the United States here, sleep labs that have very, long wait to get in the sleep lab. And nowadays, we just bypass this process by starting empiric auto CPAP therapy. A dental appliance is less effective in patients who are obese, and we're going to talk about indications in a minute. The hypoglossal nerve stimulation, we'll talk about that again in a few minutes, and it has very clear indications and specific indications. Weight loss would be helpful, but probably not the only treatment option here, given his cardiovascular comorbidities and how significant he desaturated. And we didn't get any positional data to suggest that positional therapy alone would be successful here. You can do it in addition to other things, probably. So the first question you have to ask yourself when we have someone with OSA, like, should they be treated? Should we even start treatment with someone like this? And the answer is, if someone has moderate to severe OSA, so if the AHI is more than 15 or more, then yes, we should start treatment, and we think the treatment will make a big difference in these patients. But if someone has mild OSA, if the AHI is only 5 to 15, we only treat them if they have associated cardiovascular disease, neurocognitive dysfunction, memory problems, cognitive problems, or if they're very symptomatic, they have excessive daytime sleepiness and fatigue. So we see sometimes patients getting a sleep study just because they snore, their wife or their family member tell them, oh, go get tested. The sleep study only shows an AHI of 9 per hour, for example, but they don't have any symptoms and they're completely fine. They don't have any cardiovascular disease. There is no indication then treatment will change their outcome to the better. So just remember that. And when it comes to treatment options, there are 3 major categories of treatments that we offer patients. There are surgical interventions, there are oral appliances, and there are the positive airway pressure therapies. And we'll talk about each of those in detail in a minute. In addition to behavior interventions that will just help improve nasal patency, weight loss, avoiding alcohol and sedatives, and avoiding sleeping in the supine position in general. But that's not, so that used to be, 10, 15 years ago. Nowadays, there are many, many more treatments that we can think about and consider for our patients. For example, the continuous negative external pressure device, which, hasn't gained a lot of popularity, but we still use sometimes in patients who are undergoing conscious sedation in the hospital. In Canada, I think they use it a little bit more, but it hasn't really gained traction in OSA, but it's available. Oral pressure therapy is a device that you can put, in the oral cavity and close your mouth, and it will create negative pressure, will suck the tongue forward, out of the way to keep the upper airway open. Some centers here use that commonly. This nasal expiratory positive airway pressure device, or Provent, some of you might have seen this. It's actually now, they're not manufacturing it anymore, but it used to build up positive pressure in the nasal pathway, and it will actually, keep the airway open, maybe up, equivalent to like 6 to 8 centimeters of water, CPAP, but it's not available anymore. There is this tongue stabilizing device, which is something that would just keep the tongue protruded to prevent it from falling back and blocking the upper airway. Can be used sometimes, but positional therapy is something that we use often as an additional or supplementary treatment for patients with obstructive sleep apnea to prevent them from sleeping on their back. We'll talk about that more. And then there are a few newer treatments that are really gaining traction and are very exciting. One of them is this awake transoral neuromuscular stimulation. It's a device basically that patients wear, and it exercises their muscles. I have a slide on that. Hypoglossal nerve stimulation, we're going to talk about in more detail. And then pharmacologic therapy, which gaining, again, there's a lot of interest, a lot of research going on in that field. And I'll give you a couple of examples. But CPAP, or just positive airway pressure therapy in general, has been around for 20, 30 years. And the reason why it has been so effective and has been the go-to treatment is that, once you put the mask on and you pressurize the airway, it doesn't matter where the obstruction is, whether it's nasopharynx, oropharynx, hypopharynx, the airway stays patent, basically, as long as you have the mask and the pressure on. And it does that from day one. We can treat the problem. It doesn't matter how large the neck is, how severe the apnea is. And the ways we do that, we can do this with continuous positive airway pressure therapy, where it's just one pressure continuously throughout the night, let's say pressure of 8, 9, 10. We can use an auto PAP, which we use, pretty much, very commonly nowadays, where you set a range of pressure. So a range of like minimum pressure of 5 and a maximum pressure of 20. And the device can detect if there is any airway resistance or obstruction, and it will go up or down based on the patient's needs. So it can adapt throughout the night. So that's why we don't have to do titrations. If we're going to start someone on auto CPAP, you can look at the data, download data off the machine after a month or so, and try to pick a pressure that's appropriate for them based on their, 95% of the time, for example, they're at a pressure of 12, and then that's what we end up using as their treatment pressure. Bi-level PAP or the BiPAP devices will provide higher pressure breathing in, lower pressure breathing out. So we use this in patients who require higher levels of CPAP. It's more comfortable to tolerate. People who cannot tolerate CPAP, for example. It's good for patients who hypoventilate or patients who have significant cardiopulmonary disease. It can be very useful. And then adaptive servoventilation, not for your typical obstructive sleep apnea patient, but there's a subgroup of patients who develop central apneas. They actually, stop breathing and they don't have any effort. They don't make the effort to breathe. Some people develop that while we're trying to treat them for the obstructive sleep apnea. So we use ASV to treat the combination of obstructive and central apneas. We're not going to talk too much about this modality, but it's think about it, central and complex sleep apnea. CPAP has been around for many, many years, back in the 1990s when it first came out. And throughout the years, we've seen the technology improve significantly all the way now to some of the travel kits, that are very small. You can basically carry in the palm of your hand. I'm going to run through the next few slides just for the sake of time. So it has been shown to be very effective in treating excessive daytime sleepiness. We see significant blood pressure improvements in patients who use CPAP, almost a drop of 10 millimeters mercury in MAP, systolic and diastolic pressures in patients who use CPAP versus control. In this study, for example, the concept of non-dippers that we talked about. So in this study here, they looked at the use of CPAP in a patient with moderate to severe obstructive sleep apnea, and they compared that in patients who had the natural dip in their blood pressure and patients who did not have that dip in their blood pressure. And they found that the use of CPAP significantly reduced the nocturnal blood pressure as well as the 24-hour blood pressure, especially in the non-dipper group. So patients who lost that dip in their blood pressure at night because of OSA, treatment with CPAP makes the biggest difference in that group of patients. We've seen CPAP, improve left ventricular ejection fraction on echocardiogram. We've seen CPAP reduce the risk of recurrence of atrial fibrillation after catheter ablation. And in large epidemiologic studies that looked at overall mortality, we've seen CPAP, the use of CPAP in patients with severe obstructive sleep apnea, this is the line here, has significant reduction in mortality compared to patients with severe obstructive sleep apnea who are not using CPAP. But the problem with the problem with CPAP has always been adherence. There's a very variable, a degree of adherence that we see. Patients who are followed by, in specialized sleep centers do a little bit better, but there are many, many reasons why people have trouble using their CPAP, and we just have to sit down and go over, why. We have to ask why. Is it air leak? Is it the mask not comfortable? Is it them just don't like the whole routine of using their CPAP at night? Is it a socioeconomic, problem? Is it the wrong diagnosis to begin with? Is it the pressure that's too high or too low? And we try to address all of that. When it comes to masks, people think it's like this big, large mask, but there are so many different masks out there that, patients can choose from, and they can use just the nasal. If their mouth opens up, they can use a shin strap to keep their mouth closed. And so once patients try 2-3 masks, they usually can find one that works best for them. We can download data off of these machines that can help us know how many hours of usage the patients, are using their machine every night. If there is air leak, so we can see if there is large air leak, and we can fix that by using different masks, different size of mask. We can see if they still have some residual, apneas and hypopneas, and adjust the pressures accordingly. So we've been using this to help us manage these patients and improve their compliance. So basically, the American Academy of Sleep Medicine recommendations is that we know that PAP therapy, including CPAP, give us a clinically significant reduction in disease severity, so the reduction in AHI, improvement in excessive daytime sleepiness, improvement in blood pressure, reduction in motor vehicle accidents, and improvement in sleep-related quality of life. Ambulatory CPAP initiation, so empiric auto CPAP is equivalent to in-lab titration here. They're equal in effectiveness. So we instead of wasting time and money, we just go for auto CPAP. I just mentioned that. Patient education and support and telemonitoring, should really be done to improve patients' compliance and outcome. So moving on to another treatment modality, so mandibular advancement devices or oral appliances, and the idea is, it has two parts and patients wear them, and it basically moves the lower jaw forward and pulls the base of the tongue with it to open up the back of the airway. Very simple. It's been used now for the last 20 years or so. There are many different devices out there that dentists and patients can choose from. But it has to be done right. We recommend that it's done by, dentists who, practice and do this. And here there are dental sleep medicine board certification, actually, because the protrusion has to be done very gradually so that they don't cause any TMJ problems in these patients. It is very effective. It has been shown to reduce AHI by more than 50% in 70% of patients using the oral appliance. But it really all depends on how you choose the patient. So the best candidate for a dental appliance or oral appliance is someone who's younger. Females do better than males. Someone who has a low BMI, so non-obese and small neck circumference. It is best in people who have a little bit of a retrognathia, people with shorter soft palate, and those with mild to moderate disease, and especially if it's positional, especially if they have predominantly supine obstructive sleep apnea, because the only parameter that you change, you're only moving the jaw forward and you're moving the tongue forward. So if they have positional disease, this device works perfectly fine. So if you have someone with all these characteristics, the device can be more than 90% effective in treating their sleep apnea. They don't need CPAP. The newer devices nowadays, and this is, again, an area of a lot of research, can monitor actually device use. It can monitor things like blood pressure and O2 saturation and heart rate variability. And so what's called smart oral appliances now. Actually, some are being studied. We're studying them in our sleep labs now to see if we can use them for diagnosis of obstructive sleep apnea. And some of them will self-titrate. So the device can detect the sleep apnea event and will actually protrude, like maybe by 1 millimeter, just to open up the airway and get rid of the obstructive sleep apnea. So more to come on mandibular advancement devices. Surgical interventions, there has been many interventions out there. Success rate is, it's in the 50% range. It all depends on choosing the right patient for the right procedure. And the surgery that works and is very effective, but it has a lot of morbidity, is maxillary mandibular advancement, where you break the maxilla and the mandible at these locations here, and you pull them forward. So you pull the base of the tongue forward. The reconstruction of the oral cavity, basically, very effective but very morbid. But the surgery that has gained a lot of popularity, and every patient who walks in a clinic asks me about it nowadays, is hypoglossal nerve stimulation, or the Inspire device. And as you can see, it's something that looks like a pacemaker that gets implanted in the subcutaneous tissue under the clavicle. You have a sensory lead that goes in the intercostal space, and you have a stimulation lead that goes around the hypoglossal nerve at the base of the tongue. And once that's in and everything heals, the patient at home, basically, once they're ready to go to sleep, they put this device on the remote. They put the remote on and turn the device on. There's maybe like a 30-minute lag, and then with every breath in, the tongue will be stimulated to move forward and open up the airway. With every breath in, the tongue will move forward and backward. It is very well tolerated, and the degree of the stimulation, the electric stimulation, we start with a very small amount of electric stimulation and then slowly increase that. The stimulation cuff, very important anatomically to go at the very distal part of the hypoglossal nerve to stimulate only the muscles, the protrusion muscles, basically, to move the tongue forward with stimulation. And it works, you know, so this is with laryngoscopy, you can see the base of the tongue in someone who has no stimulation. So this is the epiglottis, and you can see with them breathing in and out, the airway completely closes. This is higher up at the level of the palate, soft palate, and you can see, I mean, the airway is basically closed. And this is with stimulation. The same patient with stimulation, you can see how the upper airway opens up, breathing in and out, and then here at the level of the palate, you can see how with inspiration and with stimulation, the airway completely opens up. So it definitely works, again, in the right patient population. So what are the indications? Who is the right patient? Who is the best patient for that treatment? It's for adults, 18 years or older, non-obese patients. So there is a cutoff of 32, BMI of 32. It doesn't work very well in patients with a very large neck. Patients with an AHI of 15 to 65. So it's in the moderate to severe range. That's where the indication is. It's, at least here in the United States, we can only do it for someone who tried CPAP and failed, who cannot use and cannot tolerate CPAP. And then, you need to have the appropriate anatomy. So again, you need to see this anterior-posterior collapse of the airway. You don't want to see concentric collapse. So we want to see this because this is the anterior-posterior collapse is when the tongue is stimulated, it can open it up. When you see concentric collapse, even if the tongue moves forward, the lateral walls are collapsing and causing obstruction of the airway. So if these criteria are met, that person would be a very good candidate for hypoglossal nerve stimulation. And we know that it works. That was the landmark trial that they did, the STAR trial, to get the device approved. And they showed that, after 12 months of stimulation, the median AHI went from 30, 31 down to 7. And they had it was a pre-planned, there was a randomization for therapy withdrawal in the group here in orange. And after 12 months, they stopped therapy for, I think it was a month period, and they found that the median AHI went back up, suggesting that it was the stimulation what's caused all the improvement in the AHI in that patient population. And, that same group followed the patients for 5 years and found that these effects were maintained. So it was not just the 12 months, the effects were maintained up to 5 years of stimulation and follow-up, and the symptoms stayed very well controlled as well. Even there, there's a lot of technology and AI is getting involved here, and we're seeing ways to monitor these patients, look at their data remotely and make changes in the stimulation remotely. So moving on, and I'm sorry, you might not be able to see this very well, but the transoral awake state, neuromuscular electrical stimulation is the device that we talked about earlier, which basically is a device that's used to stimulate the tongue and basically exercise the tongue muscles to make them stronger and prevent them from collapsing when patients are asleep and lose their muscle tone and cause obstructive sleep apnea. So this device has been approved in the United States for patients with mild obstructive sleep apnea only. In this study, they used it on patients basically 20 minutes a day of stimulation for 6 weeks. And they found that the AHI dropped. I mean, yeah, the numbers are small, but it was a significant drop in their AHI and a significant improvement in their Epworth sleepiness scale. But because the numbers are small and it was only done on patients with mild obstructive sleep apnea, that is the only indication right now for patients with mild OSA. Positional therapy, again, for people who you do the sleep study and you find that they have predominantly supine sleep. Only when they go on their back that they start stopping breathing. And so if they use any of these, commercially available, devices and tools, they're fine. And I do this sometimes in patients who their AHI is maybe 20, or, on when they sleep on their back, but they flip to their side, then their AHI is 5. So all they need is just to avoid sleeping on their back. Pharmacologic therapy, so that's like a very hot area right now. A ton of research going on, mainly in 4 areas. One area is upper airway patency. How do we improve that? By, weight loss is a big one, of course. And then, nasal decongestants, or anything that we can maintain the airway patency with medications. I'll talk to you about weight loss medications in a minute. Another area is focusing on improving pharyngeal dilator function, so upper airway recruitability with some medications. So certain serotonergic medications, noradrenergic medications, K-channel blockers. I'll give you an example of a study here in a minute. Another area is focusing on respiratory control and high loop gain and chemosensitivity. Carbonic anhydrase inhibitors, something like sulfam, for example. There are a few studies that were done using that drug and using improvement in sleep apnea. And then the last area is focusing on lowering the respiratory arousal threshold. People who are very sensitive sleepers and they wake up with any sound of snoring or whatever, their sleep can be very disrupted and they have more apneas, and lowering their arousal threshold can be very helpful. And tons of studies going on in each of these categories of treatments. So that's an example of a study that used atomoxetine, which is a norepinephrine reuptake inhibitor, and oxybutynin, which is an antimuscarinic drug. It was only 20 patients, and it was only one night. So they randomized patients to either getting the 2 drugs right before they go to sleep versus placebo. And they looked at their AHI after just one night of usage, and you can see significant drop in their AHI. They also measured the genioglossus muscle activity, and they found significant improvement in muscle activity in the group that got the drugs versus the controls. Very small study, but it's very promising, and there is a lot of phase 2 and phase 3 trials now in progress, to see if these medications would just treat sleep apnea. Every patient asks, can I just take a pill to treat my apnea and not use CPAP? The other exciting data came out from the SURMOUNT OSA trial. So tizapeptide, yes, Zepbound it's called here in the United States. Similar to the Wegovy and Ozempic and all these other drugs that are being used for weight loss, tizapeptide was used in this SURMOUNT OSA trial. It was 2 trials going on in parallel, both randomized controlled, double-blind, in patients with moderate to severe OSA. And the trial 1 recruited patients who were not on CPAP. They either refused or could not use CPAP. Trial 2 was on patients that were using CPAP. And it was an international study. It was done in different continents, different countries. They randomized patients to receive either the highest tolerated dose of tirzepatide versus placebo. They followed these patients for 52 weeks. And what they found is significant improvement in AHI in patients who got tirzepatide, almost 27 points drop in their AHI from baseline in both trials. So in the group that was not using CPAP and in the group that was using CPAP. Okay. So that was, very, very, very promising data, actually. And they also, of course, seen significant reduction in BMI, improvement in systolic blood pressures, and improvement in CRP, which is a measure of inflammation in the body. So again, very promising data. So it's not only to help with weight loss, but it also significantly reduces apnea-hypopnea index. There are many follow-up trials that are happening right now to give us just more information about using this, maybe as a sole treatment for sleep apnea. So just to summarize here, so you have someone with obstructive sleep apnea, and so we get a sleep study. So nowadays, with all the data that I showed you, if they have moderate to severe obstructive sleep apnea, then I still try to get them on a PAP therapy, CPAP or BiPAP. And if they're doing well and we succeed, then fine. If they are not, if they cannot tolerate CPAP, or for some reason it's not working for them, that I would consider hypoglossal nerve stimulation if they meet all the indications we talked about, or the mandibular advancement device, at least. Again, depending on what kind of phenotype we're dealing with. If they have mild sleep apnea, then I sit down and I give them the whole menu of treatments and look at if they have predominantly supine sleep, look at their anatomy, see if they would, fit, meet criteria for an oral appliance, maybe the ESCT, that the neuromuscular stimulation device, and so on and so forth. So we individualize our treatment that way. But really, the future of treatment of obstructive sleep apnea, and maybe this is just my last slide here, is that we try to identify the right, endotype and phenotype, of disease in that particular patient that you see. So if you're seeing someone who is, for example, obese, of course, so weight loss, weight reduction surgery, maybe bariatric surgery, maybe one of those, weight reduction drugs would be the way to go. Someone who has, maybe the right anatomy for a specific surgical procedure, someone who meets criteria for an oral appliance, positional therapy. If, hopefully we'll get better at knowing that if someone has a genioglossus muscle problem and we just need to improve recruitability of their muscles, then we do either, that daytime neuromuscular stimulation device or hypoglossal nerve stimulation, or use one of the medications to improve their muscle recruitability. If someone has an arousal threshold problem, then we use the right medication for that. A loop gain problem, we do that, So I think treatment will be individualized. It's no more, CPAP for everyone who has obstructive sleep apnea. I think we're going to get better at sitting down with the patient and giving them a whole range of treatment options as we better understand the mechanism and the pathophysiology and maybe some of the epigenetics that we talked about to identify who's at risk of redeveloping all the cardiovascular comorbidities and who's not. So the take-home points, obstructive sleep apnea is very common, but remains largely underdiagnosed in the general patient population. Untreated OSA can be associated with multiple negative cardiovascular, neurocognitive, metabolic consequences, as well as daytime sleepiness and impairment. We need a better severity index, that correlates with outcomes. So when someone has that level of severity, they are more likely to develop this kind of comorbidity. There are novel technologies that are coming up, for diagnosis, and that hopefully is going to make patients' life easier to make the diagnosis of the disease. And then PAP therapy remains the mainstay of treatment for moderate to severe obstructive sleep apnea, but alternative treatments are coming out as we talked, and really personalized approach to treating patients with obstructive sleep apnea is the way of the future. And thank you very much, and sorry for running a few minutes late, and I'm happy to take any questions and respond by email, after the conference. And I'll try to join in when you're presenting this talk to answer any questions you might have, but we'll see how it goes. Thank you very much, and best of luck.
طبعا دكتورة إيمان متشكرين. ثانك يو فيري ماتش. دكتورة إيمان مهتمة جدا بالسليب ديس اوردرز، وكانت بتقول لي واحنا قاعدين العينين اللي هيخشوا عن شمس التخصصي عندهم سليب ستادي، وطبعا انا بفاصل معاها، وبعد شويه تقول لك احنا عندنا دلوقتي فاصل مقبلين على الزواج، كل واحد قبل ما يتجوز يعملوا سليب ستادي لغايه ما نوصل الى دراسه للنوم لكل مواطن في مصر ان شاء الله يا دكتور ايمان.